Thank you very much. If that's too loud, let me know. I don't want to boom out somehow. I'm just going to start with a quote. It takes two to speak the truth, one to speak and another to listen. So I appreciate today, that's by Henry Thoreau, that you're here to listen as I bring forth some information that through our work at the Southern Alberta Clinic, we saw as very important information around gay and bisexual men's health, and it's those that are HIV positive and are being impacted by interpersonal violence. So I'm going to take you through some of our findings and why we think it's important to put this information out there. This research has just been accepted into an HIV medical journal, so it's actually going to be published, which is great news because it gets people talking about it and recognizing it as a social issue, a health concern. So now let's see if I got this right. Okay. So just to give you a little bit of background, what is interpersonal violence? We went to the WHO, so the World Health Organization, and basically their definition is any behavior in an intimate relationship causing physical, psychological, or sexual harm. It's important to note it's not often studied among gay and bisexual men, which means, and this is my piece, that either we are more socially tolerant, which means we just sort of accept it as being there, or maybe we're socially ignorant. We don't want to deal with it, right? And so we're just not touching it, and we're not opening up dialogue. Our research then is to looks at reconstructing the social health discourse specific to interpersonal violence, HIV, gay and bisexual men's health. A little bit of background. IPV, so interpersonal violence, is a risk factor for HIV acquisition among women, and increasingly it's recognized among gay and bisexual men. It's associated with behaviors conferring poor HIV-related outcomes. That's both physical and mental health. Also, IPV's impact is starting to be acknowledged. Acknowledged as impacting an HIV-positive person's quality of life. That's my day-to-day living. So as you live every day, how does this begin to impact how you think, how you feel, how you are in your relationships, how you are in your workplace? So some of the goals we had within this study, we wanted to look at prevalence and the subtypes. Subtypes are just the different categories. We broke it down. And that actually helps us know how do we become more effective in being helpers, whether it's in the HIV clinic or out in the community. We wanted to look at clinical associations. Some of that is to look at whether it's more illness related. Is there certain illnesses that are coming up around the prevalence of IPV, or mental health, addictions, things like that. We wanted also to look at some of the outcomes, basically health-related, quality of life. We asked a question specific to that. We looked at some of the psychiatric outcomes, issues such as depression, anxiety, and we didn't look at PTSD, but that's something we did want to look at. Continuity of care, around looking at if someone is experiencing IPV, interpersonal violence, would it impact their ability to be able to come in and seek out the care they needed to be living with HIV. So we actually saw it as a barrier. And then clinical outcomes, we also looked at the prevalence of the illness, HIV illness turning into AIDS, as well as the number of HIV-related hospitalizations. And we also wanted to look at creating information to develop preventative and intervention healthcare strategies. So here's some of the methods. Basically, when patients, we call them patients, that term in itself can seem a little bit derogatory because you are people living with HIV when you live with HIV. But this PowerPoint is set up off of the actual article, so I'll just allow that to be in the presentation. It was patients from May 2009 actually until December 2011. So pretty much 2 years worth of patients that were at the Southern Alberta Clinic. And we actually created our own screening tool because when you're in the Southern Alberta Clinic, it's mandatory in Alberta healthcare that we do ask if you're currently living in an abusive relationship, anyone that comes in for healthcare, But you ask that at the first visit, and really at the first visit, people are just so overwhelmed that, to say, yes, I am, it's just like a burden. It's another thing to deal with. So we got smarter, and we decided that when they came in for their next full visit, where they're really going to be in the clinic for a period of time, where we could have a conversation, where we could make the space, that we created a longer version of the screening tool. So the inclusion criteria for this study is self-reported sex as male and self-reported sexual orientation as gay or bisexual. Oops. Oh, there we go. Okay. I'll do this just in brief summary, because basically what this shows is just our method of screening. When we are going to have that conversation, we spend a little time with people, and we just talk about that it's common for people to be living with interpersonal violence in their relationships, but we don't want it to be common. So we're going to ask some questions to see if we can be a better support, and then the questions are you currently living in a relationship where you're experiencing interpersonal violence? Have you previously experienced it? And we also ask if you experienced any interpersonal violence as a child. If someone says no, then that's done. If someone says yes, if they're currently living with interpersonal violence, then right away we ask them if they would like any support. Some people say no, and some people say yes, and support can be just a conversation, or support might be some more resources. And really it's an opportunity to connect with that person and just to see what they really need. In my own practice in the clinic, a lot of times I was doing counseling with gay couples, and sometimes they're just looking for a space to sort it out. And they haven't had someone to either support them, or they're feeling a lot of pressure from just dealing with life. And sometimes the HIV is causing, just that diagnosis has caused a lot of pressure on their relationship, so they're just needing a space. Even in my PhD research, which of course is separate, it's a qualitative study. So it's a participatory action research project where we're actually gathering in the community serodiscordant couples. And I have to thank AIDS Calgary, or Calgary Cares, for allowing there to be a community space now that serodiscordant couples can come and just talk. And it's a peer support model, and they support each other. And really, sometimes that's what we need. We just need a space for dialogue. But in the clinic itself, we actually ask the questions around if you are experiencing interpersonal violence, and then we look at how do we best support someone. And just so you know, around the methods, yes, we're keeping a database. We are looking at all sorts of analysis around the data. Some of this, to me, is just more about, we want to know demographics, and some of that is how long you've been living with HIV, your CD4 count, location of HIV diagnosis. So these are just things we're keeping track of. So here's the results. Of 739 gay or bisexual males engaged in care that were screened for IPV, 22.4% reported that they were living with IPV, either current or in the past relationship. So current relationships, 14.9%, previous, 90.9%. That's a high number, right? When we did this study, of course, we assessed it out for everyone, every HIV patient. So the average for the total clinic, that's all people living with HIV, is 35%. And the average for the gay population is 22.4%. Okay. So these are some of the things. We'll just break it down a little bit further. When you look at those relationships, what we also found that people that were disclosing IPV were more likely to be Aboriginal, younger men, victims of childhood abuse. They had experienced depression prior to diagnosis. They were using ongoing psychiatric resources. They had recently participated in unprotected sex and have poor to fair versus good to excellent quality of life. They also have a higher rate of clinically relevant interruptions in care, and that date, when they use that data, it's more than 180 days that they haven't come back into care. So care at the clinic looks like every 4 months, which is about 120 days you'll come back in, see your doctor, see your nurse, whatever you're needing for support. People that didn't come in that 180-day mark onwards, we said that at this time there was an interruption to their care. And that was more prevalent for those living with IPV. And there was also more HIV-related hospitalizations. This is a breakdown on the demographic information. It's hopefully okay as far as size-wise to read. This information I think is going to be distributed, so I'm not going to spend a lot of time. I think it's part of the conference package. Okay, great. I think a couple things just to note. If you look at the average age, 43.8, that was the average age of all the participants. But remember, I said those most at risk were younger. So that's always interesting to consider out the supports they might need. Kind of relates a little bit to your discussion as well. And another stat that stands out is, of course, the Aboriginal population for gay men is at higher risk. And the prevalency of child abuse. So that means not only have you experienced it in your adult life, interpersonal violence, you've experienced it in your childhood. Oops. And these are just some of the stats around mental health. Really no difference between those experiencing IPV and not around alcohol abuse, but it looks like the numbers for illicit substance abuse are a bit higher, as well as smoking. You will see, though, depression, which was noted, it's almost double, a little less than double, higher rates of anxiety, and higher rates of having to be involved with psychiatry care, which isn't a bad thing, because if you need it, it's important that you can have it and you can access it. And it is something that our clinic, we do have a psychiatrist that is available a couple times a month just for people to be able to check in and get any support they need. And these are just some of the numbers around unprotected sex since last visit and sex since last visit. Health-related quality of life. The big one was you saw more people with fair, right? And not really getting to good, really good. Those numbers, very good. We have lower amounts. Good, there's kind of a category where we're equal to those not living with IPV, but we have a high number of people living with fair and poor. And those are people currently living with IPV. And this is just to do with continuity of care, which again, we saw that there's increased risk that those living with IPV and HIV are more at risk at not being able to come in for their care. That could be to do with many factors, but we know that IPV is very hard on your mental health, right? And so if you're not feeling good about your life, or someone is telling you that you're not a good person, it's going to be really hard to come in and maintain your care. And these are just some of the clinical outcomes. The only one I'm going to note that I think is important is hospitalizations. What we looked at is those that are experiencing IPV have a higher rate of HIV-related hospitalizations. And so that's something to think about. Is it the stress of being burdened with IPV and HIV that mounts up, right? It's confounding factors. And so there's higher rates of hospitalizations for that population. So some of the limitations of this study, it's self-reported, right? And also gay and bisexual men were studied together. And they may, and I think we need to just assume they would experience it differently. There's always some difference. Anytime you kind of make it homogeneous, you're taking away, right, the fact that there is always a different lived experience around sexual identity. So some of the conclusions they'll bring forth, there's a very high prevalence of IPV, 1 in every 4.5 of those living with HIV. It's associated with Aboriginal ethnicity, childhood abuse, psychiatric disease, risky sexual behavior, poor health-related quality of life, interruptions in care, and progression to AIDS among those presenting early. Early means that you're diagnosed early. And there's a higher incidence of HIV-related hospitalizations. So some of the conclusions. IPV isn't important, but it's actually very under-recognized social comorbidity, which means it exists with HIV among HIV-positive gay and bisexual men. We need more studies, and we have been looking at that and trying to get, our own. We've written a couple of proposals to further look at its impact, but more so, what do we need to do so we could better prevent it, because it's very preventable. Evidence-based interventions we need more of to identify victims and provide effective support may improve well-being for a substantial proportion of HIV-positive gay and bisexual men. And I think only because I've had the opportunity to sit in a peer support model around serodiscordant couples, you can see sometimes they just need to be able to talk. If there's a new diagnosis around HIV, one of the things I noticed is it puts a lot of pressure on the relationship. And sometimes they need a place to talk and other people to support them through that this is normal, to be angry, to be frustrated, to not know what to do. And if you can have a safe place to do that, where no one's going to judge you, maybe we could decrease some of these numbers around IPV. Bye. Thank you very much. And lastly, we need knowledge transfer, and it's needed between helping professionals in order to reduce the impact of IPV. And what that means is if someone goes to their doctor to get their HIV care, if the other professionals aren't communicating and maybe someone knows that there's strain in their relationship, but that's not transferred over, the doctor just deals with the medications. And in health care, I think it's a great opportunity to be able to work with people on many different levels, because really our emotional care is as important as our health care. And lastly, I just want to acknowledge the Southern Alberta Clinic and all the staff that were involved in this project and continue to be involved in this project because it's not over, and they're still working hard to prevent and to do intervention when needed. That's it. Thank you.